Welcome all of you. So this is one of the first event in a new series IAPS Pro, where we are like embarking upon certain areas of pediatric surgery, which are not usually very much practiced by the pediatric surgeons across the country. So the first in this series is upper and lower GI endoscopy. Maybe we are planning in future to touch upon certain neurosurgical procedures, plastic surgical procedures, cardiovascular procedures. So this is just my thought, and it's a beginning. I'm very happy to have Dr. Akshay Kalawant, who took this initiative, and he said that he will take the lead in this particular program. In fact, he's planning to organize a fellowship course also very soon. And we have with us Dr. Amit from AIMS Patna, who is going to moderate this session. We have with us today our president of Indian Association of Pediatric Surgeons, Professor Sumit Biswas. I'll request him to say a few words of blessing so that we can proceed with the meeting. Biswas, sir.
This is a nice endeavor from our Secretary General, and he has so many brilliant ideas coming to fruits. I have every support for him. I welcome all of you to this past endeavor in GI endoscopy. Thank you all.
Thank you so much, sir. Over to you, Dr. Amit, for conducting the session further. Introducing Dr. Akshay also.
Okay, thank you, sir. So once again, a very good evening to all of you present here. And today we are very excited that we are going to start on GI endoscopy and pediatric surgeons. And to talk on this topic, today we have Dr. Akshay Kalawant from Mangalore. Dr. Akshay has done his MCH from PGI Chandigarh and has a special interest in pediatric urology, oncology, neural tube defects, and obviously GI endoscopy. So without wasting much time, we'll ask Dr. Akshay to take over.
Yeah, thank you, Dr. Amit. I know Dr. Amit because he's also into endoscopy now. So that's how we had exchanged our thoughts. And thanks for the introduction. At the outset, I'm very thankful for the our honorary secretary for giving me an opportunity, and not only that, to actually basically motivating me for giving this talk, and he has also been motivating other young people also. So that's so nice of him. So I'll straight away go to the topic. So pediatric surgeon and GI endoscopy. I have put pediatric surgeon first here because we have to start. Pediatric surgeon has to start thinking about GI endoscopy, and then we have to include or inculcate that in our regular practice. That's what my whole intention of this talk is. So at the disclosure, I would like to tell you all that I'm a general pediatric surgeon performing general pediatric GI endoscopy, not complicated, not something hi-fi. So another important intention of this talk is to motivate the pediatric surgeon to take up GI endoscopy in a big way. Okay, the agenda of the talk is the surgeons and endoscopy. We'll talk about how surgeons have contributed to the endoscopy. We'll talk something about basics of endoscopy. We'll talk about indications of endoscopy in children, a little bit about the training, and let's talk about some case snippets in pediatric surgery. Now, the first slide I would like to talk about is why surgeons should continue performing flexible endoscopy. Now, I have used here word continue because there has been immense contribution from surgeons in field of endoscopy, and slowly over the period it has been seen not only in our country, but rather even American Association of Gastrointestinal Surgeons. They also have felt that the training for their residents are also slightly declining, and they are of little worry that if some interventional endoscope has to be done, in that case there will not be many surgeons who have been trained because slowly the field has been taken up by medical gastroenterology. So the first thing is the large contribution from the surgeons are very much there in the history. We are going to talk about that in the next slide. Now, surgical training, we have a better hand-eye coordination, and that's why we'll be able to pick up these skills quickly. This is basically skill-based procedure. So if you can learn laparoscopy, thoracoscopy, other scopies like cystoscopy, bronchoscopy, it's not very difficult for us to pick endoscope. Only thing is we need to have little orientation. Pediatric surveillance after post-op cases, this is actually onus of a surgeon. So if you have done gastrojejunostomy, you have to follow them up. You have done retrosigmoidoscopy, you have to follow them up. It is onus of a surgeon to follow these patients up. So how can you do that? We can do it with the help of endoscopy, and we need not be dependent on other specialists to help us out in following up the cases. Management of complication of endoscopy is another very important aspect, because any complication related to endoscopy, the surgeon has to be in the background. Say there's a esophageal rupture, surgeon has to pitch in. If there's a gastric perforation, if there's a colonoscopy, colon perforation, again, it's a job of the surgeons to set it right. So we have also seen a patient, of course, adult patient coming with the guide wire in the mouth, which was stuck in the papillae. So if that is the, of course, we had to do a laparotomy, duodenotomy, and take it out. It was some 1.5 decades ago. So when surgeons can take care of the complication, why not the surgeon himself do an endoscopy wherever required? So surgeons have different perspective on looking at the in performing endoscopy. Like we're not just diagnostic, we have a future thinking. So when we see some pathology in the lumen, so we also have a foresight of how we can treat these patients, how we can plan the management of these patients. So we have a little different perspective of looking at the diseases compared to the medical colleagues. And the disease as identified, some of the diseases which are identified, especially in children, the shares are more. They are relatively children who require endoscopy are likely to have some surgical intervention. So why do we why can't we involve ourselves from the beginning rather than taking the consultation at the end? So these are some of the points which should actually stimulate us to take up endoscopy. These are not my words. This is from Ishwarmurthy Sundaram. He is a very passionate minimal access surgeon. So this is taken up from his personal point of view. That's 10 reasons why surgeons should continue performing flexible endoscopy. Now, this was I was talking about. See, if you see many of the contribution, these all are from surgeons. So whether it is colonoscopy, that is Dr. Turrell had suggested how to design a colonoscopy. If we are to talk about the control of the hemorrhage, it is Gasford or Sugawa. And in previous era, people wouldn't dare to do a polypectomy because they had a very high chance of bleeding. So it was Shinya, that is Hiromi Shinya. He's a Japanese surgeon who devised snare and used electrocautery for removal of the polyp. Variceal banding was actually devised by Stitchman. PEG, here it's very interesting. PEG is percutaneous endoscopic gastrostomy, which was actually a brainchild of Michael Cadwell. So he's a pediatric surgeon. So you should be proud of it. And he inculcated that that thought into Jeffrey Ponsky. He's a well-known surgeon who is into advanced endoscopy. Is him. So they devised what is known as because the pediatric surgeon was very much concerned about the gastrostomy that he was doing for neurologically debilitated children like CP. So they together devised PEG. So biliary stenting. Nip Sohindra, he is an Indonesian surgeon. Later he established himself in Germany. So he was instrumental in taking ERCP to a greater level, and he's very much instrumental in getting the biliary stenting into practice. Now, Inoue is one person who has taken it one step more. He has devised what is known as POEM. POEM is peroral endoscopic myotomy. So at the same time, we should also appreciate the surgeons from India. So the below are the surgeons from India who have dedicated themselves to take up only endoscopy. They have left their surgical practice and they're into very complicated endoscopy procedures like Dr. Amit Maide, Amor Bape, Dr. Advay Ahe. So they are doing fantastic job in the field of endoscopy. Now, let's talk a little bit about orientation of the endoscopy. So we all have seen this. So as a general surgery residents, we have seen in the endoscopic suite. It is just to stimulate you that or take you through a ride in the how does it look like, so that you get little bit oriented. So this is an endoscopy which is totally flexible. This is, we are talking about flexible endoscopy, and colonoscopy and upper GI endoscopy both looks the same. So here there are uh, so many switches and buttons over here, which is used for controlling. Say there is suction valve for suction, there is air or water valve to let the jet of air or water, and there's instrument port over here, there's a camera over here, there is deflection knob. I'll show it in the next slide. So this is how the end of the endoscope looks like. There's a bigger channel is always for the instrument channel, because they give us the access to do some interventions, a biopsy, to put a clip for hemostasis. And there are different light channels over here, so that if one get blocked, the light can be shown by other ports. So there is accessory water channel if you want to inject more water. So there is insufflation of the air and insufflation of the water takes from this channel, and this is the lens. So this is how a tower of endoscopy looks like. This is the screen, everybody knows about it. It's something like our laparoscopic instrument tower. And this is the camera. This is very important part of the endoscopy. And this another is air insufflator. So with this, we insufflate air. And this is important stand, because we have to keep this endoscope in this stand. Otherwise, it can get damaged. Now, this is how we hold the scope. If you are right-handed person, we hold it with the left hand. And this is the big wheel. And this is the small wheel. So big wheel is for up and down, and small is for right and left deviation of the tip of the endoscope. And with the same hand, with our fingers, index finger and the ring finger, we manipulate the switches for suction and air insufflation. And with the right hand, which is free, we direct our scope into the patient's orifice or lumen. So I'm not going to go into great detail. It is to show you that there are gastroscopes. That is where with which we do upper GI endoscopy, and it has little less range of movement, but they are softer and a little smaller, and the length is also shorter compared to the colonoscope, which is little more sturdier because it has to go all along the colon, and they have little wide range of movement because they have to negotiate through a lot of curvatures. They're little wider, and at the same time they're little longer. So this is the
ஐடியா இருக்கு அடிக்கடி இந்த மாதிரி போஸ்ட் எடுத்து நான் பெருசா அதெல்லாம் எனக்கு திறக்க கூட இன்ட்ரெஸ்ட் இல்ல.
so this is
தெரியல
the
அவளோட ஏதோ
I'm
ஒரு
not
இதுக்கு
going
அவன்
to
ஏதோ
go into
அலோவ்
great
பண்ணல.
detail here, because maybe I'll cover up in the next talk, where we are going to go into great detail of what are the different types of scope, what are the different types of product that's available. Now, one thing this is very important for us to know is the orientation. So we all are well familiar with our orientation. We do many surgeries, open many surgery laparoscopically, we do cystoscopy. So at the same time here, the position matters, because most of the times our patient will be supine when we operate, but here it is completely lateral position. This is a very favorite position for performing the endoscopy. But we may have to do in different position as well. Say for example, we have to take out endoscopic foreign body rectal from the esophagus, we might have to put the patient on supine position. But this is by and large very common position which is used for endoscopy. And at the same time, we should get oriented to ourselves. The patient is not supine, so once we put the scope inside, the our larynx will look something like this. So first we have to get access into the esophagus, where we go into the hypopharynx over here. Can you see my cursor? Can you see my cursor here?
Yeah, we can see it.
Okay, so this is the hypopharynx over here, and we get the access of the esophagus through one of the side of the hypopharynx. We cannot go into in the midline because the cartilage is such that we cannot go. We have to take one of the side, and we have to enter the esophagus. Now, once we go to the esophagus, we should be very, very clear about the anatomy, where what you see in the 12 o'clock position is actually is the right side of the patient. What you see in the 6 o'clock position is the left. Similarly, what you see in the 3 o'clock position, that is over here, this is the posterior aspect of the patient, this is anterior aspect of the patient. So once you get going, you'll be able to understand the anatomy well. You need not keep in mind, it's like driving a car. Initially, it might be very difficult to coordinate the things, but once you start working with the scope, it's not a very great difficulty for us, because we know the orientation of the esophagus, we know the surgical anatomy very well. At the same time, we should also know how the mucosa or how the lining looks like. So these are the normal mucosal lining over here, but sometimes we may end up in a patient with the abnormal conditions where the normal anatomy, anatomical picture, what we know, will help us in leading us forward. So this is the lower esophageal sphincter. Most of the times it will be closed, and once we insufflate, it opens. It's something like when we do. I'm trying to give you example of the regular pediatric surgical scopies or laparoscopy so that you can grasp it. So once we do a cystoscopy, so the bladder neck opens up with our infusion of the saline. So similarly, once you do an insufflation of the air, it opens up. And when you enter inside, this is the rugae, gastric rugae, which is normal. And over here in the 3 o'clock position, you will have pylorus. And this is the pylorus that you have, and there's a pyloric opening over here. And this is how it looks. This is the duodenum, second part duodenum. It looks like a well. So these are the common anatomy that we come across when we go into this intraluminal anatomy. So at the same time, we also have to look at the fundus, where we do a J-shaped J maneuver, or it's also known as retroflexion maneuver, where we see the roof. On the 3 o'clock position or 2 o'clock position, it is a lesser curvature. On the other side, this is the greater curvature, which is on the 3 o'clock position to 5 o'clock position is the anterior surface of the stomach, and in the 9 o'clock to 10 o'clock position, the posterior surface. You can rotate it all the way, and this orientation might change. But when you do a retroflexion maneuver, the initial thing that you see over here is these orientations. Now, at the same time, colonoscopy is slightly difficult in the sense the length is longer and all the segment looks almost the same, and you really do not know that where you are heading towards and where you already headed already, because there are so many curvature over here. So this requires little more practice, and complication rate of colonoscopy is slightly higher compared to the upper GI endoscopy because of the same reason that this is slightly, there are so many curvatures over here which we need to overcome to reach the cecum. So once you are able to intubate the ileum, that is said that you are a real expert in colonoscopy. But our intention is to go at least till cecum for fairly good colonoscopy. Now see this, you can see that there are so many places where you can get entangled, or it is known as loop. So loop is once you go into the lumen, you try to progress, but this forms a loop like that. So, but the one loop which forms initially is known as alpha loop. And once you go there, the second loop might be formed. You might not realize that the loop is forming unless you're a real expert, because you know that once you push the scope, it's not going according to how you are pushing it. It's not progressing well. And meanwhile, it can form another loop that is known as beta loop. So we should be aware of this situation so that we can troubleshoot when we come across this situation. You pull the scope back and you make a rotation maneuver. If you have a alpha beta loop that is at the distal end, you may pull it out. If you are having an alpha loop, which is in the sigmoid colon, you have to use rotation maneuver to overcome it. So this is the descending colon and ascending colon will look almost the same. And once you reach this splenic flexure over here, it will be like a den or cave, like you have to go inside, and you may have to hook the splenic flexure over here and then push the scope so that it goes inside. And once you reach this hepatic flexure, it's like the dead end. You'll not be able to see the way forward. So then you really have to look into where could the opening be, and then slowly glide through that to reach the what is known descending colon and then further cecum. So if you go a little more further, you'll be able to see even appendiceal opening from internal opening of the appendix. And in that fold over here, I cannot show the appendix opening over here, but at least I can show you the fold over here, which is on medial side. You can go into the ileum. So intubation of ileum is a tough job, and most of the times for children, we need not go for ileum intubation. Especially unless we are thinking in terms of inflammatory bowel disease, where strongly are suspecting Crohn's disease, we might have to enter the ileum. And transverse colon is the one which gives a triangular shape. So once you are in triangular shape, see a triangular shaped shape of the lumen, that means you are in the transverse colon. Now, question is, how is pediatric endoscopy different from adult endoscopy? So that is a usual debate which will be happening between pediatric and adult medical gastroenterologists. So we will try to sort it or find out what are the differences. First is indication is different. So we treat different kinds of patients, not like adult. Adult, the first thing they come to their mind when they talk about is maybe malignancy, or certain alcoholic liver disease. So there are different types of patients, but we are dealing with different types of patients. Like we might have to deal with congenital problems, we might have to deal with extrahepatic aortic obstructions. So diseases are different. So our thinking process also differs as the caretaker of pediatric patients. Cancer prevalence is very low. Now, surgical indications are very likely in the patient with child going for endoscopy, especially for intervention endoscopy. And instruments. So choosing an instrument is also very challenging because we deal with different sizes of the patient. So which instruments, which size instruments to be chosen. So that's also has, and we cannot afford all the instruments to be bought. So unless it's a big institution which can provide you, but as a private practitioner or you're in a hospital which is not a very corporate hospital, a nursing home, it will be difficult to take by array of instruments. So you should be very careful in choosing the instruments. And this statement that pediatric endoscopist can never gain experience of the adult endoscopist. So this is, I have taken it from a paper from ESPGHAN, that is European Society of Pediatric Gastroenterologists and Hepatic and Nutrition. So they say that the per se, the number of children requiring endoscopy is very less, and hence the exposure required for the pediatric endoscopist is much, much lesser. So certain procedures like ERCP, the mastering requires performance of many scopies for that matter. It's not achieved by a pediatric endoscopist. So that's where we need to have more understanding as well as more hands-on to reach that level. Now, anatomical differences, of course, there are anatomical differences like if you can see this stomach, the gastric angulation over here is quite acute in children. So you might have to make some maneuver over here, a turning maneuver to reach the pylorus. Pylorus will be somewhere here. But in adult, the stomach size is bigger. So as soon as you enter the stomach, just over here, you'll be able to see the pylorus in the same view angle. Colon is not fixed structure. So because of which, and it's not fixed structure and it is very fragile. So both of this makes us difficult intubation of the colon. And but one good thing is you can do manipulation with your hand over the abdomen of the child because abdominal wall is not very thick. So you can manipulate it. Sometimes you can see the light coming from the endoscope through the trans-abdominal wall. So that will also be helpful in identifying that where we have reached. And of course, looking at the internal anatomy also, that requires some time for us to understand that. So that's why that makes the colonoscopy a little difficult. Other things which concerns us is need for sedation. So the children, most of the gastroenterologists, they do it under sedation, but as a surgeon, most of the times we have to perform therapeutic endoscopies. We prefer to do it, even though it's a diagnostic, at least I would prefer to do under good anesthesia care because the child will be very safe. That's because surprisingly, it was noted that complication rate in upper GI scopy was more than colonoscopy, which is not the case in adult. In adult, they say that colonoscopy, the chance of complications are higher compared to upper GI endoscopy. But in children, it was noted that it is 2.3% of the child undergoing upper GI endoscopy has complication. And in that, they have noticed that 1.5% is related to the anesthesia-related or sedation-related complication. So that's why we want our child to be safe. So we do it in OT setting. It's not that all the patients are intubated, but at least they are in monitored anesthesia care. And we should be very careful while insufflating the air because more insufflation can cause perforation. Also, it can cause splinting of the diaphragm, especially when you're doing gastroscopy. So most of the times, anesthetists will be worried when we are doing gastroscopy because they'll be always worried about their ventilation. Now, next question comes, what are the size that one should use? Of course, this is a natural question because we have different patients who are coming to us and most of the hospital will have standard adult upper GI endoscope. So which is about 9.8 millimeter in diameter. So can we use that? So this is a recommendation from NESPGHAN, that is North American Association of Pediatric Gastroenterology and Nutrition, Hepatology and Nutrition. So where they say that it is preferable to use 6 millimeter gastroscope for children less than 10 kilograms. But here they again mention that you can consider using standard adult gastroscope if endotherapy is required. So when you go in my future side, you'll get to know that most of the conditions for which we do endoscopy are for therapeutic procedures. So it's always valid to use this particular scope because if you use smaller scope, the therapeutic spectrum of that scope reduces because the channel working channel is low, the visibility is little poor, the wide angle of the vision is reduced. So that's why it's always for us it will be very helpful to use standard adult gastroscope, and it's quite valid to use standard adult gastroscope in children. But only thing that has been mentioned is if you are using standard adult gastroscope, it has to be done under general anesthesia, especially for pediatrics. And of course, when we are doing therapeutic endoscopy, we often use general anesthesia for these patients. And what about the colonoscope? Colonoscope, there are dedicated pediatric colonoscope available, but you can get away by using pediatric upper G endoscopy for colonoscopy. It might look weird that we use the same scope from the top and same scope from the bottom, but we do that. So we use upper G endoscopy for colonoscopy. But only thing is the upper G endoscopy will not be very sturdy. It will be a little softer, but that is okay for children because their colon is also softer. I mean fragile. But only thing is the pediatric upper G endoscopy doesn't have the complete range of movement as colonoscope. Colonoscope has movement on either side, this side as well as the other side, but pediatric or adult gastroscope, upper G endoscope for that matter, has only one range of movement, and other range of movement is not very much. So that could be one disadvantage. But nonetheless, we will be most of the times able to enter the even ileum with the help of standard scope. Now coming to the indications of GI endoscopy in children. See, you can see so many indications for doing upper GI endoscopy. These are the therapeutic endoscopy on in the center over here. And these are the indication for not doing. We should not be just doing endoscopy because there are a lot of concern which has been shown in few papers that there are many contenders. The contenders for doing endoscopy in children have increased, and probably the indication has slightly liberalized, and they're using endoscope for many required patients. So there's a concern. So it's very clearly written that for GR, we are not going to do endoscopy. For functional GI disorder, we're not going to do endoscopy. So that has been very clear. And at the same time, diagnostics. See, you should understand that there are so many conditions for diagnosis, which is a domain of gastroenterologist. Pediatric gastroenterologists, of course, they have a different way of looking at the symptoms like weight loss, failure to thrive, unexpected anemia, and suspicion of graft versus host diseases, GI allergies. So they are fabulous specialists in that matter. I must say that because they come to a diagnosis that it will be very helpful for the children to come out of these conditions. But at the same time, there are certain diagnostic scopies which could be done by surgeons, like hematemesis, hematochezia, to look for the source of bleeding, to look for caustic acid injection. We should look for the assessment of the esophagus. So all these things could be done by surgeon. So I'll do one thing. I'll go to the next slide and make the things simple. So if you want to know that what are the indication for endoscopy, so there are two things which we can divide it into. One is we do endoscopy because we do not know what the cause is. We are trying to identify the cause. Failure to thrive, diarrhea, recurrent diarrheas, chronic diarrheas, anemias, screening of certain diseases like celiac disease. Celiac disease, I must say that it's a disease of North India. I must say here I should make a divide between North India and South India, which is very much true because we see very less, almost nil, I would say, celiac disease. So recurrent abdominal pain. So these are the one which is usually the domain of pediatric gastroenterologist. So rather see the right side. GI bleed, foreign body in the GI tract, dysphagia, corrosive injection assessment, surgical follow-ups, tumors, need for biopsy, polypectomy. All these are the domains where surgeon can pitch in. He can treat this, identify this. So we should concentrate on the right-hand side, basically, rather than left-hand side. Now, let me even divide it further. Like, what can we do? I have divided into three parts. Let's see the last part, that what we cannot do. So first I put over here is ERCP. Now, indication of ERCP is very less in pediatric patients. So we do get patients for ERCP, especially little older children, 9, 10, 12 years old, with the chronic pancreatitis. Yes, of course, they do require, but the numbers are very low. And in certain places in India, there are very high chance of pancreatic diseases. So maybe there they might get a, but otherwise the need for ERCP is very, very less. So again, spending time on learning this and getting it, and it requires a high skill for getting this procedure done or doing this procedure. So I don't think that we need to really work so much on this, because ultimately we will not get much patients, and we are not really going to treat these patients. And for that matter, even pediatric gastroenterologists in most of the places are also not exposed to ERCP. They of course take the help of adult gastroenterologists to do these procedures. That means to say that this is a difficult job, because it's like, say, urologist working with the stones. So even though we know the anatomy of the urologist, pediatric urology well, but the stones, not most of the pediatric surgeons are aware of. So we do take the help of the urologist. So similarly, pediatric gastroenterologists also take the help of adult. So I don't think we need to venture in this area at all. Next is endoscopic submucosal resection. This is usually done for malignancy. Again, it doesn't come under the scope of pediatric disease treatment. Endoscopic treatment of gastroesophageal reflux. Of course, there's a treatment for the esophageal reflux disease. There are the gadgets used for that, but this requires dedicated team, and at the same time, the gastroscopes used for this are different. So they have wider diameter, which cannot be used in children. And next is peroral endoscopic myotomy. So this is one of the excellent treatment for achalasia cardia, and it works very well for adult patient. Again, for children, the cost is high. They have bigger scopes for this procedure, which a smaller kid cannot take it. And most of the times, Heller's myotomy, which we do laparoscopical open, they do quite well for children. So again, we need not spend our time on these things to master it, because it requires real mastery to get into these procedures. Now let's see which we need not do. Like I have already discussed, diagnostic endoscopy for medical disease, the different section of the diseases which requires further workup of the condition. So just doing an endoscopy is not enough for here. So we not venture into this particular field. And endoscopic ultrasonography is coming in a big way nowadays. Adult endoscopists are using it very often, especially to look for lymph nodes, pancreatic masses, pancreatitis, to assess the pancreatic pseudocyst. But endoscopic usage in children is very less, because we have transabdominal ultrasonography, which gives quite fairly good information, and we need not really go for endoscopic ultrasonography. Most of the endoscopic ultrasound sonographic endoscopes are 15 mm in diameter, so which is very big for children. So we cannot think of using it in small child. Now, cystogastrostomy decompression is one of the common procedures nowadays done by gastroenterologists. Again, nowadays the standard of care is usage of ultrasonography, endoscopic ultrasonography to puncture the cyst, because there is always a fear of puncturing or injuring the gastric vessels, which can cause torrential bleed. So now the standard of care is that. So that's why, again, people may try that, but again, it's not that everybody could master it. The complication rates are higher. We have other minimal invasive technique for our own patients. In surgical manner, we can go do that. Enteroscopy is slowly now picking up in adult population. In children, it is little less popular, because we don't deal with many of the intestinal diseases in children, small bowel disease in children. And again, it requires little sturdy scopy, and with the tip, which is very soft. So again, that sturdy scope, proximal part, it won't go enter into the esophagus, or it might cause more damage. So again, it's not, in near future, it is not going to be very popular in pediatric usage. Now, what can we do? We've already discussed tumor, foreign body, intralesional injection. Intralesional injection, we can use glue, we can use adrenaline. Glue can be used in gastric varices. Adrenaline can be used for small ulcers, which is bleeding, that can be taken care of. Diagnostic colonoscopy or polypectomy can be done. Dilatation. When we perform treatment for tracheoesophageal fistula, we do anastomosis. We can as well dilate ourselves with the help of endoscope under guidance. Variceal band ligation and percutaneous endoscopic gastrostomy. So these are things which can which as a surgeon we can really think forward of. So this is the one which we should aim at. Now this is the setup of the pediatric or rather any endoscopy suite. Now I am just highlighting the endoscopy which is done in the OT. So this I am taken from a gastroenterology unit. Our hospital, our department also performs in similar manner, but this is a ERCP which is being done over here. So we have a good OT technician or ERCP technician or endoscopy technician. Their help is immensely required for us. There should be CRM, there should be anesthesia monitoring system, and you can see that there are 2 monitors over here, so that we don't get fatigued. We can always see on both the side, and we can perform the endoscopy. And at the same time, there are we should also have one additional recording system also, which is usually not associated with this, which is connected to the computer, which is nearby. Now, next question is training. The question really, some of the people would ask is, should we attend certified courses? At present, it is not mandatory. It's not that if you have to do endoscopy, you need to be certified. So we perform many scopies as pediatric surgeons. We do endoscope, we do bronchoscopy, rigid esophagoscopy, cystoscopy, thoracoscopy, laparoscopy. So it's not difficult for us to get hands-on this and perform this scopy. So, and we know the disease as well. So it should not be that it's be difficult for us without a certified course. We are well versed with the different diseases. We are well versed with different anatomy of a child. So we can, I think, we can still get away without getting a certified course. But what if we have a certification in endoscopy? How helpful it is? Now, thing is, we are dealing with costly equipments. So if a hospital has to provide us with the equipment, they should be confident that the person can perform this scopy well. So complication arising out of endoscopy, I've already told that most of the times we'll end up doing therapeutic endoscopy. So in that case, complication rates are higher. So if that is the case, then people or the other cross specialists can question that whether he's really certified. And nowadays, patients are also might be very inquisitive. They might ask the qualification whether this whether the surgeon is, because they know that endoscopy is done by gastroenterologist. So whether pediatric surgeon is doing, they might ask regarding qualification. That might help us in that way. And it also helps us to learn the things or learn the procedure in a more systematic manner. This is also very important for us for a streamlined learning. So if you get a opportunity to learn formal endoscopy, it's actually a welcome call. Now, where can we get trained? I'm not going to go into great detail here. We can discuss in maybe in the next session in detail, but this is just to overview that, see, the number of cases are very less. So accumulating the case is one of the very important or very tedious job. So if you think in terms of short-term training and long-term, it should be associated with long-term mentoring. In short term, you cannot learn everything. In the same time, you cannot spend a lot of time because number of cases are less. So it should be a short-term training with long-term mentoring. So now because of small cases, you might have to go to the person who is well versed with endoscopy whenever whenever the person gets patients. Like for example, a patient comes for corrosive injection, you cannot wait on that person. You will have to immediately post the patient and do a procedure. If the patient has foreign body in the esophagus, we cannot wait for somebody to join you so that you can teach them. So that is one problem that we have. And again, searching a mentor is also a tedious job because not everybody will be doing the endoscopy. Next is another common way in which you can enter is learn the endoscopy in adult center and apply that in pediatric patient. We know the pediatric disease as well. We know the pediatric anatomy well. We can apply that, but you have to go through an adult learning process in adult patient. So there are so many centers which I'm not going to name now, but they charge hefty amount, something like 80,000. It may range from 30,000 to something like 1 lakh. They use most of the times adult principle. You might get more hands-on in these courses, and at the end, what you get is you get a certificate at the end of your course, which might be very helpful for you to start the endoscopy or to ask a request to your hospital to provide you one. Now, another way in which you can go is attending the workshops. So here you will not get live patients to work on. Most of them you will have to work on mannequins provided during the workshop. So you will get to handle the scopes well. You'll get to interact with the faculty, but problem is it will be on dummies or on a mannequin. Nowadays, there are the companies of the scopes and gastroscopes also. If you buy one, they actually send you for the training. So again, that depends on which center they're sending you for the training, whether that person is interested in teaching you or not. But whatever information, little bit information you get, you can always you can adore it and use it for your practice in future. Now, next is the regular courses are actually conducted by associations. You must have heard the name AMASI, Association of Minimal Access Surgeons of India. So where they conduct regular courses, and here they also acknowledge pediatric surgeons also in their courses. I have seen their brochure where they have certified course where even pediatric MCH pediatric surgeon, MCH gastro is basically the gastroenterologist, but MCH surgical oncologist, they are also allowed. So they acknowledge. There's one good thing I've seen in that brochures. So they are certified courses, but only thing is most of the times they'll be crowded. So the and again there'll be most of the times mannequin, one or two hands-on uh, training might be provided. Again, you can use this module also to learn. Now, what is the hindrance of us not taking up endoscopy? One is lack of training. In certain centers, there are training in MS General Surgery residency, but nowadays I'm seeing that most of the time, most of the centers are slowly taken up. The endoscopy is taken up by medical gastroenterologist. So lack of training is one. And when we reach MCH or DRNB training in pediatric surgery, uh, most of the center they do not have training for residents. So even if we have some exposure during MS or DNB, that touch is also lost. So we might not continue our endoscopic procedures in our practice. Cost of equipment actually, and cost of equipment as well as less number of cases that we have as a pediatric patients. These two work in combination, and they discourage us from investing on scopes. And same thing for even bigger hospitals also. They won't invest much on pediatric scopes. Established gastroenterology department in the working hospital, which is already running, they might not encourage the newer people to join. So we need to have somehow good rapport with them and then get our case done. But last one I'd like to emphasize is not considering the endoscopy as a part of a specialty. Because anyway, we are not dealing with this particular aspect much. Anyway, there are already specialists who are taking care of. Let them take care of it. So this kind of attitude, this is what I just wanted to make a change in. So rest of the things somehow we can overcome. But if we can overcome the last point. Now, this is a assessment list for the trainee. I have taken it from the European Pediatric Gastroenterologist and Hepatology and Nutrition Society. You can see that here they are assessed like in this form, whether the trainee is able to intubate the esophagus well, examination of stomach well, pyloric intubation is possible or not, where they have been able to intubate and demonstrate duodenum or not. Similarly, here the sigmoid colon, they have cross sigmoid colon, they have gone cross splenic fracture, intubate the cecum, they have intubate the ileum. So this is how it goes. So that means these are the higher level of endoscopic skills that we have to acquire when we learn endoscopy. Let's quickly go through the snippets. I hope I have some time now. This is just to show you that okay, we can do certain endoscopies which are really helpful in treating our patients. Let's go one by one. So this was a 12-year-old child who presented us with a gastric mass, palpable gastric mass. CT was done outside. We had only one film. It was in a government hospital. We did not have a CD, which showed that they had made a diagnosis of GIST. So outside medical gastroenterologist had done endoscopy, which was done 15 days back. They said that the mucosa is normal. They could not find any mass there. Maybe the mass grew after that and we were able to palpate better. So we did an endoscopy, and meanwhile we had done a CT scan in our center. So they said that there's some mass. They could not come to the conclusion. They said probably just. So when we entered into the stomach, this is the anterior part of the stomach. There was a mass lying over here, but this was a kind of bosselated mass like this, and there was a mucosa over it. So we did a biopsy. I thought that this could not be just because that's usually a round tumor, and it has grown faster compared when I saw the gastroenterologist's report. He has said that he could not see a mass, so it has grown faster. So then I had a doubt whether really are we dealing with the GIST. So I tried biopsy taking from here and sent it for frozen section, which they said that this is just a mucosa, we cannot see anything. So then we took a trans-abdominal biopsy. So this was the advantage for us, because once something is not working, we could immediately shift to the other modality, because the child was intubated. The child was we are strongly suspecting a mass. So anyway, we are working up for the case, and it turned out to be lymphoma. And finally, it turned out to be Burkitt's lymphoma. And then we went back to the CT scan, where we saw that there is a maintenance of the architecture of the vessel which is going through the tumor. And finally, it turned out to be lymphoma, Burkitt's, and it was treated by our hemato-oncology team. And then now child went home. Now he's under follow-up under hematologist. So these are the changes that we really can get if we take armamentarium of endoscopy into our practice. Now this is very interesting. This many of you might come across. 2-year-old child presented with the difficulty of swallowing and not gaining weight for almost a year. So the child had difficulty for solid and less for water. This is very important. History is very important. Although this history was not given very clearly by the mother in initial history taking. Then again, we went back to the mother and asked. At that time, she realized that maybe what we were asking is important, and she told this. Then, of course, for dysphagia, we had asked for a esophagogram. Can anybody tell, looking at this picture, what it could be? So this was reported as achalasia cardia. Of course, it looks something like achalasia cardia here. We do endoscopy for all the achalasia cardia. Thing is, if you do endoscopy for achalasia cardia, the lower esophageal sphincter dilates and we'll be able to feed the child well. And after 3 to 4 weeks, child will be able to gain at least 1.5 to 2 kilograms of weight, and we can take the child up for Heller's myotomy. When we did endoscopy here, there was a rigid ring over here. It was not a achalasia cardia. Anybody? What it could be? So this is actually Schatzki's ring. This is known as Schatzki's ring. We cannot, is a very fibrous ring which we cannot enter this. So then we had to do dilatation, and after two dilatation 4 weeks apart, we could avoid surgery in him, and now he is under follow-up, and he did not require any surgery. So the endoscopy that we had done in surgical unit has changed the total diagnosis. Change the diagnosis, and at the same time we did an endoscopic dilatation, and that was the end of the treatment. So looking at this report, and if I not an endoscopy, maybe the child would have landed up in Heller's myotomy. So that's the importance of the endoscopy in this particular patient. Now this is another interesting case which we had come across. 11-year-old child presented with hematemesis and melena. There's no history of any abdominal distension, abdominal pain, or no abdominal tenderness, and the child did not have any other illness. So in view of hematemesis, we did ultrasonography. There was no evidence of portal hypertension as well. So we were thinking in terms of some next thing that we think about is any acid peptic disease. So we went inside. So it was not surprising us, because you can see that this is duodenum, the well-like appearance. That's why I told you that anatomy is important. And there was in anterior wall of the duodenum, there was an ulcer. And similarly, there's a posterior also there's ulcer. So we thought that, okay, this is the cause of ulcer. Since there was no active bleed, we did not do any intervention. Others, we can use injections, we can use clips, hemostatic clips for this. So we just came out. Then we realized that the patient is having acute distension of abdomen. So patient was in OT. So we did an C-arm. In the C-arm, we noted that there is a pneumoperitoneum. So without wasting much time, we discussed the case with the parents, and we said that the child requires immediate laparotomy. This was a perforation of the duodenal ulcer. Probably perforation happened because of our intervention, but we could immediately identify that. As a surgeon, it was not difficult for us to even go immediately into the abdomen and close the perforation with the patch. So there was hardly very less contamination, and the recovery was very quick. Now, if I have time, I'll just continue with 2 more cases. I think, can I continue for another 2-3 slides?
We have only 10 minutes left.
Okay, I'll go through this. Okay, now these are I just wanted to show that, yeah, this is.
I just go through fastly. Okay, yes.
Yes. So this is where our surgical pediatric surgeons doing a scopy is very helpful. This is a child who presented to us with the long gap TEF, and we had done gastric pull-up in this child, and he presented us with sudden onset dysphagia. And we knew that because we know where our anastomosis is, we know what is the condition of the stomach, how it is pulled up. So we know the anatomy of this. This is surgical anatomy, rather than the actual anatomy. So there was a foot bolus in the uh, anastomostic side. So we could take it out and we then did a scopy. So this is stomach in the thorax. Now, this was I was talking about surgical anatomy. So this is a case of ureterosigmoidostomy done for extrophy bladder in a 13-year-old child. Now he has grown to, this had done around 8 years back. Now he has grown into adult. He would never come for endoscopy. Now they had to call him for endoscopy because we need to do surveillance of these patients for any malignancy. I could see all these polypoidal thing. Now, if you ask other endoscopists, they might not be knowing what a surgeon has done in this patient because this is the ureteric opening which is there in the rectal pouch. This is a rectal pouch to which we have joined the sigmoid colon. So now I am showing you the rectal pouch, and this is the ureteric opening which is joining over there. So only the surgeon who has operated will be able to demonstrate the anatomy and be very clear that what is happening with the child. And we have taken a biopsy. This biopsy has come as normal mucosa. So of course he requires regular follow. Now this is again use of different gadgets. This is a zip which was stuck in the esophagus, which was removed with the help of snare, different gadgets. In fact, this is a snare for taking out the solid foreign bodies. So here we had used first initially biopsy forceps followed by snare to take out the zip. This is the foreign body stomach, in the stomach which was reluctant to go into the pylorus. After 3 weeks we had taken out the foreign body. So this is, even banding is not very difficult job. Only thing is you have to get oriented. You can do banding also in patient with extrahepatic protein obstruction, and you can also enter the jejunum also. If you're well versed with the skill, you can enter the jejunum and you can look for the villi. So sometimes patient with celiac disease can have loss of villi, especially in duodenum. They can also have tropical sprue can also have loss of villi, atrophic villi, that can also be detected in this. Solitary rectal ulcer will present like this. Patient coming with the chronic bleeding per rectum. Not always it will be polyp, it could be solitary rectal ulcer. Now this is a duodenal esophageal dilatation for the patient who had consumption of battery and causing esophageal stricture. Under ultrasound guidance and C-arm, we perform esophagus dilatation with the Savary-Gillard's dilators. So we'll be talking about different gadgets in probably next session. What are the gadgets that's available? What can we use? How can we convert the adult gadgets into the pediatric gadgets? We can discuss in the next session. Now, how to move forward? Basically, we need to create interest within ourselves. Most of the medical adult gastroenterists are not very comfortable handling children. We should understand. So we should take more interest in getting into this field, and so that we can gain more experience. In summary, I consider that endoscopy is an important armamentarium in the management of children with GI problems. So learning curve is not steep for surgeon. That's what I want to stress here, because we have been already exposed to different types of scopies. It's not difficult for us. We need to get the endoscopy into the curriculum. I'm requesting all the teachers who have visited this, so that all the residents can already, by the time they pass out, can have the endoscopy, have scopic skill, and they can build their further practice on that. I'd like to thank Dr. Venkatesh Annigeri, who is right now in Dubai, but who was very instrumental in getting the endoscopy in our institution. And he, as I already discussed, that children below 14 years of age are dealt by pediatric surgeon. This is because of him. And this is our team. This you must be knowing him. He is Dr. Surendra, who started the pediatric gastroenterology program in India. He is a very nice person who would be very helpful. He would be very welcoming to help young people who would like to learn endoscopy. He's presently working in, he was in SCPJ, now he's in Aster, Bangalore. And this is Dr. Anil Halgeri. He's kind of mentor to us. Most of the diseases that I have showed you is already always has been discussed with them. We have been moving forward. This is Dr. Prashant, who is colleague of mine, and this is our very good neonatologist in the city. So at the end, hope my talk has inspired at least one teacher so that he can inspire many more students, or one young surgeon who can inspire or motivate many more colleagues. These are my references. Thank you. Thank you so much.
Thank you so much, Dr. Akshay, for your excellent thought-provoking talk. And it has not sensitized one. I'm sure that it has generated lots of interest among the pediatric surgeons.
Thank you, sir. Thank you so much.
Because quickly we can see the questions in the chat box. So somebody wants to know the precautions for complications, excessive insufflation identification.
Sorry, I didn't get the question, sir.
Somebody wants to know what are the precautions for complications and excessive insufflation identification.
No, actually, there is no particular guidelines, or there's no particular way in which we can see the how much insufflation. There's no meter there to see how much.
Yes, right.
It is basically experience based. So
rather, I would like to add that why do you want to achieve the maximum insufflation? Do with the minimum.
Yes.
Don't set your highest, how much more I can insufflate. That is not the point. How much minimum insufflation is necessary to give a good anatomical picture, I think that is more than enough.
Yes, absolutely.
And regarding complications, it is like a blanket question. Complication is there at each and every step, and it can be dealt by isn't it?
Yes. So first question was ileal intubation, inflammatory bowel disease, TB, mural thickening, biopsy, lymphoma. Yes, inflammatory.
He was actually telling you the indications of endoscopy while you were showing in your slide. So he added few indications,
Okay,
Dr.
okay.
Basant Kumar.
Yes. Okay. So appropriate size for pediatric patient, age, weight related, what size commonly used? Yeah, I've already discussed this. Usually we use standard adult gastroscope, which is available everywhere. So the smallest that is available in our country is 6 millimeter, which is by Olympus, which is very delicate scope, and it doesn't have much option for, of course, it has channel for working, but it has small channel, so we cannot use it really for intervention. Yeah, somebody has answered the Shaski's ring, right? So what scope are you using for children less than 10 kg? So we try to avoid doing endoscopy below 6 kilograms of weight. Above 6 kilograms under general anesthesia, we use adult standard endoscopes. I have been using adult endoscope for, yeah, the comment is about it. Of course, we can use standard endoscope for about 10 kilograms. That is 9.8 millimeters, which is available. We can use with careful manipulation. We can use up to even 6 kilograms weight also. Dr. Pratibha is asking that how do you identify beta loop in colonoscopy? How to manage alpha and beta loop, see if and when it arises. So we have already discussed this. Beta loop is which is at the tip, most distal, most proximal, I would say, in the part of colon. So this comes with basically when we push the scope, it doesn't progress further. And once you pull it, that time, if it comes easily, that is beta loop. And if it doesn't come, you need some manipulation, still you're unable to pull it out, that is alpha loop, which happens in the sigmoid colon. What anesthesia do you use for endoscopy and colonoscopy? Do you use lignocaine spray prior to the endoscopy? And yes, of course, we use lignocaine spray. But in the smaller child, we should be very careful. The lignocaine spray can absorb very faster, and this is in the oral cavity. So they can have immediate absorption, and it can have immediate CNS effect. That has to be kept in mind. So if that is the case, we use 2% lignocaine diluted regular solution. We use it. Only for older patient, we use the spray. And anesthesia that is used for diagnostic scopy, we use patient will be under sedation with the nasal prongs on, and we'll be doing endoscopy. For if you're suspecting difficult endoscopy or some intervention, we prefer based on anesthesiologist, however they are comfortable. most often we'll be using endotracheal intubation. For colonoscopy, we use laryngeal mask airway because for colonoscopy, we need to have a relaxed abdomen. The child should not be struggling because chance of perforations are very high. So some of the anesthesiologists they're not comfortable with the laryngeal mask airway, so they tend to intubate, and that is all right for me. So is there any other question which people would like to ask? They can unmute and they can ask, or anybody want to share, because definitely there are many pediatric surgeons who are doing endoscopy. My intention was to sensitize the people to take up endoscopy. That's so there are many centers who are doing endoscopy. There are many pediatric surgeons who are doing endoscopies. If you have
So,
anything to share, you may.
Akshay, I have a suggestion for you.
Yes.
Can you brief the audience, like what is your future plan? Like we have 3 talks lined up,
Okay.
and maybe you have worked a lot to have a live course also. So can
Yes.
you brief the audience about it?
So basically, the 3 talks are, one is just to today to sensitize that what a pediatric surgeon can do, and based on that, I am looking forward for little more people to join the next talk, which would be the logistics of using an endoscope. How to what are the different products which are available? What are the different gadgets that we have? How to set up a practice? Basically, number of patients that we have is less, so we'll have to negotiate in certain places, and how can we move forward if we are planning to do it in a bigger institution or we are doing a private practice. And the third talk, I would be making it more interactive. I would like to invite people who are doing endoscopy to put in their view and also their experience. And we can have an interactive session where I would just want to highlight the troubleshooting for initial beginners. So what are the places where they have problems? We can discuss over that, and people who are already been doing endoscopy, we can have little further discussion that what are the different problem they have faced and how can we tackle this. So I'm also planning to request some of the people who are already doing endoscopy to come in as a panel and we can discuss over that. So as far as the training on the endoscopy is concerned, it was always I was been thinking that the pediatric surgeon should be taking up endoscopy. Well, the thought came, especially in pediatric surgery, thought came when I discussed with Dr. Ashish Minocha. So he's also a strong propender of the fact that the pediatric surgeon should be doing endoscopy. So after that, I realized that yes, there is a real need. Although I've been doing endoscopy, but I had not realized that the number of people who are doing is very less. So in that regard, we can plan for as already our honorary secretary has made a platform for UA to get a uh, observership or kind of hands-on for people who are interested. So for that, we may have to make a structured program. Right now, we have not done any, so we'll have to start doing it. I have already taken permission from our institution, so they have given a green signal. Now I have to see the workout on the logistic, and then we had to spool in the cases. That's a difficult job to do, and then with the permission of our honorary secretary, we can get the course started. So I'm looking forward for that.
Somebody wanted to know, do we need technicians? So I would just say it is essentially a teamwork, and a lot many people are required around. A sister is there, and some technicians should be there, and anesthetist at one hand. Everybody has a role, and it is always a luxury to have an anesthetist at your side because we are dealing with pediatric cases.
Yes.
So for we are venturing into a new area, and some untoward things happen, that will be a absolute full stop. So always take help from anesthetist and have a good team, I would say.
Actually, I must say that technicians are one of the backbone of endoscopy because they have so much of experience. See, because they'll be assisting adult almost all the cases. Like there'll be 1 or 2 technicians who will be assisting 5 or 6 consultants. So they would have seen more endoscopies than what you are doing. So you
Right.
know the indications, you know the intricacy of anatomy, which they know, but they're not as they're more practical oriented. So I have learned a lot from our technicians. I must say, I should admit here, and they actually have taught me so many things also during the process. So certain things, when we get stuck in certain situation where there's a bleeding, you're not able to see, so taking out the foreign body, the manipulation that is required, it all requires a lot of help from the technicians as well.
Thank you, Akshay. It was a beautiful talk, and I think, like Amit said, not one teacher or one student got inspired from you. And one thing which I understood, like as a senior teacher, we should buy endoscope in pediatric surgery departments, and we should start doing endoscopies so that residents get exposure during their MCH only. Because a right beginning is the residency. You can learn anytime. There is no age for learning. But that is one thing which I take it as a take-home message. And Basant Kumar Saab is there. Yeah, everyone is having a lot of praises for you. And we look forward to other two talks as well as your live course getting started very soon. Thank you, Dr. Amit, for joining us and giving your
Hello.
precious time. Yeah,
Yeah, I am Dr. Jayakumar from Tamil Nadu.
please.
I want to clarify something about qualification. All pediatric surgeons are eligible to do endoscopy, colonoscopy because it is in our curriculum. Don't bother. If you when you can do bronchoscopy, all scopies, you can do endoscopy also. And one more thing, whatever would be the complication, we can manage because we are surgeons. Don't bother. No need to rush to some other people. Okay, qualification wise also, we have to get some help from our seniors or juniors somewhere. You get it, get trained. That's all. It's enough. Because I am doing endoscopy, colonoscopy, ERCP also. Because in Tamil Nadu, I am in a small town. I am working in medical college, but I belong to a small town. I have to deal with adult patients also. So I have to learn everything. Then cost wise, if you are an individual surgeon, definitely it costs something. Minimum 15 lakhs for refurb-based instruments, it will cost. When I completed my NCH, I bought all the things. Endoscopy, colonoscopy, bronchoscopy, all scopies. So if you want to be a complete surgeon, you have to do all scopies. You should try to own all scopies. Otherwise, make some nearby, make friends with the other pediatric surgeon and buy the scope. The work load is less with the pediatric patients. I am dealing with adult patient also. That's why it's not matter for me. Uh, then anesthesia. When you are talking about anesthesia, whenever you are doing endoscopy for pediatric patient, always do in general anesthesia. Don't go with the sedation. It happened. What happened is you take the foreign body from the esophagus and put it into the trachea. It can happen. Why you are taking risk? Do it comfortably. Under anesthesia, it is very safe. Sometimes it can struck when the cuff was insufflated, endotracheal cuff. During removal of the foreign body, just ask your anesthetist to deflate the cuff. The foreign body will come out very easily. These are all my tips. And one more thing, if time permits, I can present yes, a video which I presented in the last PESICAN. The videos of what are the things I have done in endoscopy, colonoscopy.
Yeah, Dr. Jayakumar, we will involve you in future talks. It was so nice of you to coming forward, and we will, Akshay will plan out and we will involve you in the future discussions, of course.
Okay, sir.
Yeah. So I think this, with this, we call it a day. And thank you very much, everyone, for joining this meeting. Thank you, Akshay. Thank you, Amit.
Thank you. Thank
And
you.
thank you, all the
Thank you
audience.
so much, sir. Thank you so much, and happy Holi to all of you in advance.
Happy Holi to all of you.
All of you.
Yep.